If you're living with sciatica, diabetic neuropathy, or any kind of nerve pain after 60, there's a strong chance your doctor has already prescribed gabapentin or pregabalin. Maybe you've been taking one of them for months. Maybe you've been on it for years. And maybe you're starting to wonder why the burning, tingling, and shooting pain still hasn't gone away, and why nobody warned you about what these drugs actually do to your brain, your kidneys, and your independence after 60. I'm Dr. James Hargrove, a board-certified internist with 30 years of experience treating seniors. Tonight, I'm going to give you the complete, honest picture of these two medications, how they actually work, what the long-term side effects really are after 60, and what the research genuinely supports as alternatives, because most patients are never told the full story when the prescription is written. By the end of this video, you'll know exactly what questions to ask your doctor, what natural options have real clinical evidence, and exactly when these drugs are doing more harm than good. Before we begin, type, "I deserve the truth" in the comments below if you believe seniors deserve full information about their medications. And tell me your age. I read every comment personally. What are these drugs? Gabapentin and pregabalin are both classified as anticonvulsants. They were originally developed in the 1990s to treat epilepsy and seizures. Over time, researchers discovered that they also reduce nerve pain signaling, and they have since become two of the most widely prescribed treatments for neuropathic pain in America. Gabapentin is also known by its brand name, Neurontin. Pregabalin is sold as Lyrica. Both work through similar mechanisms. They bind to specific calcium channels on your nerve cells and reduce the release of neurotransmitters that carry pain signals to your brain. In simpler terms, they don't fix the cause of your nerve pain. They turn down the volume of the signal your brain receives. This is critical to understand. They mask the pain. They don't treat it. And after 60, that distinction matters more than at any other point in your life. Do they work? Studies validated by the American Academy of Neurology show that gabapentin and pregabalin can provide moderate to significant relief for two specific conditions: sciatica, caused by spinal nerve compression, and diabetic peripheral neuropathy. For these two conditions, many seniors experience real reductions in burning, tingling, and shooting pain. But the same research shows that the benefits are far more modest and sometimes non-existent for other types of nerve pain, such as phantom limb pain, post-surgical nerve damage, or fibromyalgia-related pain. In those cases, the medication may be doing very little while exposing you to all of its side effects. Here's the part most patients are never told. For some people, these drugs simply don't work, no matter the dose. Yet patients continue taking them for months or years, because nobody reevaluates whether they're actually helping. Dosage and kidney function. The maximum approved dose of gabapentin is 3,600 mg per day. Pregabalin ranges from 150 to 600 mg. Both medications are cleared from your body almost entirely through your kidneys. Here's what most prescribing doctors don't adjust for. After 60, your kidney function naturally declines by roughly 1% per year. Standard doses that were perfectly safe for you at 50 can quietly accumulate at 70, amplifying both the effects and the side effects to dangerous levels. If you've been on gabapentin or pregabalin for more than a year, your kidney function should be checked at least every 6 months. If your doctor hasn't ordered a creatinine and eGFR test recently, request one. This is non-negotiable for safe long-term use after 60. Side effects. The hidden risks. The most common side effects are drowsiness, dizziness, and fatigue. For a 40-year-old, these are inconveniences. For a senior over 60, they are catastrophic risk multipliers. Falls in older adults are the leading cause of serious injury, hospitalization, and loss of independence in this country. Over 36,000 seniors die from falls every single year in the United States. If gabapentin or pregabalin is making you unsteady, slow, or foggy on your feet, that drug is increasing your risk of the most dangerous event after 65. Report it to your doctor immediately. Don't wait until you fall. But the side effects don't stop at falls. With long-term use, the concerns get worse. Extended use of these medications has been linked to memory problems, cognitive decline and brain fog, difficulty finding words, slower thinking, and mental fatigue, mood changes, increased anxiety and depression, physical dependence, meaning the body becomes accustomed to the drug, and stopping suddenly can cause withdrawal symptoms like anxiety, insomnia, nausea, and, in some cases, seizures. The most serious risk: opioid interactions. Perhaps the most serious risk, one that almost no patient is fully warned about, is the interaction with opioid pain medications. When gabapentin or pregabalin is combined with opioids, including hydrocodone, oxycodone, or tramadol, the risk of respiratory depression increases dramatically. Your breathing can slow to dangerous levels. In vulnerable seniors, this combination has been responsible for hundreds of deaths each year classified as accidental overdoses. Make sure every doctor on your care team knows every single medication you are taking. Bring a complete, updated list after every change. A real-life example. Frank's story. Frank, a 73-year-old retired electrician from Indianapolis, came to my office last fall after his wife noticed he was unsteady on his feet. He was taking 200 mg of gabapentin 3 times a day for diabetic neuropathy. Within 6 months of starting it, he had fallen twice in his garage, broken his wrist once, and his daughter said he wasn't himself anymore. Slower, more confused, withdrawn. We checked his kidney function. His eGFR had dropped to 45, meaning his kidneys were clearing the drug at about half the speed they used to. The medication had been silently accumulating in his system for months. His prescribing doctor had never rechecked. We tapered him slowly off gabapentin under careful supervision. Within 8 weeks, his balance returned. His mental clarity returned. His daughter had her father back. We did not eliminate his neuropathy, but we addressed it differently. Evidence-based alternatives. Here's what almost no patient on these medications is told. There are evidence-based natural alternatives that, when combined, can significantly reduce or even replace the need for these drugs in many cases. 1. Specific B vitamins. Deficiencies in B vitamins are dramatically common in adults over 60, especially in seniors taking metformin or proton pump inhibitors. Vitamin B1, thiamine, essential for the energy metabolism of every nerve cell. Deficiency directly impairs nerve conduction and is strongly linked to peripheral neuropathy. The fat-soluble form, benfotiamine, is significantly more bioavailable for older adults and crosses into nerve tissue far more effectively. Vitamin B12 maintains the myelin sheath around your nerve fibers. Low B12 slows nerve conduction, leading to tingling, numbness, and weakness. Up to 43% of adults over 60 have low or borderline B12 levels. The most absorbable form for older adults is methylcobalamin, ideally taken sublingually. Vitamin B6 supports neurotransmitter production and nerve repair. Warning: too much B6 can actually cause neuropathy. Stay within recommended therapeutic ranges and supplement only under guidance. Before starting any of these, get your B12 and B1 levels tested. Correcting a real deficiency often produces meaningful symptom relief on its own. 2. Alpha-lipoic acid. While not a B vitamin, alpha-lipoic acid is a powerful antioxidant studied extensively for diabetic neuropathy. Multiple clinical trials have shown significant reductions in burning and tingling with consistent supplementation, as it reduces oxidative stress in nerve tissue. 3. Physical therapy. A qualified physical therapist who specializes in nerve pain can identify exactly which positions, movements, and postural habits are actively making your nerve pain worse and teach you how to change them. For sciatica, your spinal position during sitting, sleeping, bending, and lifting makes an enormous difference in how much pressure is on the affected nerve root. Treatment built around your specific imaging, MRI or X-ray, is dramatically more effective than generic stretching advice. 4. Topical pain relief. While topical options won't treat the root cause, they meaningfully reduce day-to-day symptoms during flare-ups without systemic side effects. The 2 most evidence-supported topical options for nerve pain are capsaicin, depletes substance P, the the neuropeptide responsible for carrying pain signals. With repeated application, it progressively desensitizes nerve endings. Arnica montana has well-documented anti-inflammatory properties for nerve and joint pain. 5. Addressing the underlying cause. If your neuropathy is caused by diabetes, blood sugar management is the single most powerful intervention. No vitamin or medication manages diabetic neuropathy as effectively as reducing chronic high blood sugar. If your nerve pain is caused by sciatica, structural issues like a herniated disc need targeted attention. Medication manages the pain signal, but physical therapy, posture work, and decompression exercises address the compression itself. Critical safety reminders. Never stop gabapentin or pregabalin abruptly. Both require a gradual taper under medical supervision. Never combine these medications with alcohol. The combination dramatically amplifies drowsiness and fall risk after 60. Do not drive until you fully understand how the medication affects your alertness and coordination. If you're taking any opioid medication alongside either of these drugs, ensure every doctor on your care team is aware. If the medication is not providing meaningful relief after a reasonable trial, typically 8 to 12 weeks at an appropriate dose, have an honest conversation with your doctor about alternatives. The bottom line: gabapentin and pregabalin are legitimate medical tools for nerve pain. For some patients, they help meaningfully, but they work best as part of a broader, holistic approach that includes targeted nutrition, structural physical therapy, topical support, and, most importantly, treatment of the underlying cause. The goal is always to need medication for the shortest time possible at the lowest effective dose, while your body does the deeper work of healing. You deserve to make this decision with full information. If this video gave you something useful, share it with someone managing nerve pain. They deserve to know what Frank knows, what Margaret knows,